very good questions. And as you've already pointed out, chronic hepatitis B is a real challenge to think about the notion of cure, in large measure because it is a highly latent virus with a very stable form of in the nucleus of the infected cell, the covalent closed circular CCC DNA, that is extremely difficult to eliminate once established. In persons with chronic hepatitis B, our goals, at least to this point, have really been more modest, and these include suppression with nucleoside analog treatments that block the HBV DNA polymerase, which of course is the engine of HBV nucleic acid replication. There are new classes of therapy, as you've implied, that give us, I think, hope that we will be able to enhance the rates of functional cure, namely the loss of surface antigen in chronically infected patients, which is a highly elusive endpoint on nuke therapy alone. So these other classes of therapy include inhibitors of other life cycle steps, the most prominent of which would be the assembly of the virus, aided and abetted by a protein known as the HBV capsid protein. There are a number of inhibitors of these capsids called capsid assembly modulators, which have an antiviral effect and whose antiviral effect is actually additive to the effect of nucleoside analog therapy. And it's quite possible that these capsid assembly modulators may also work on other steps in the life cycle, including replenishment of the HBV CCC DNA in the nucleus. So there's excitement around that class, and another class of therapies that block viral protein production by specifically targeting HBV nucleic acids as they emerge from the nucleus. So, for instance, there is an HBV transcribed RNA that emerges from the nucleus to be translated into viral proteins, and this so-called pregenomic RNA can be the target of therapies known as either RNAi, inhibitory RNAs, or oligonucleotide antisense molecules that can again bring about the degradation of these mRNAs and prevention of the translation of the products. The attractiveness of this class of therapies is that this can actually knock down levels of proteins, including surface antigen, as well as other key proteins that are responsible or necessary for viral replication in the viral life cycle and virus virion production. And then another class of therapy is really immunotherapy. And these, of course, are therapies that are directed against the immune responses or directed at enhancing immune responses that have become much more feeble during chronic infection. And these approaches range from therapeutic vaccines to antibodies to exhaustion molecules such as PD-1 that would potentially be upregulated during chronic infection. So the premise here is that by restoring these responses, we may be able to enhance functional cure rates by allowing the T cells to recognize chronically infected cells that they don't recognize ordinarily during chronic infection. So I think the promise really lies in the fact that I think therapies that are targeted against that immune response, which is again weakened during chronic infection, are likely to have, I think, a disproportionate impact on our likelihood of obtaining functional cure. And the reason I say that is because when we talk about the ability to achieve functional cure, the best example of that is actually the spontaneous clearance of hepatitis B during natural acute infection. And so in persons who have mature immune responses, namely adults who undergo treatments, or I should say who experience acute infection, clearance and functional cure is the rule rather than the exception. And so these individuals eventually lose surface antigen and develop strong neutralizing antibody responses in the form of anti-HBs. And what's clear in those patients is that they have excellent and broad T cell responses against hepatitis B. So what we are looking to try to do in chronic infection is to try to really reinvigorate those responses and essentially pave the way for a response, a clearing or curative response that might be seen in acute resolving infection in persons who are chronically infected. And so can we, in fact, simply emulate that roadmap that we see in acute infection? So I'm excited about approaches that would tweak that immune response pathway, again, potentially in conjunction with some of the other classes of therapy that I described earlier that work on specific viral life cycle steps, including the RNAi pathway, which is responsible for surface antigen production itself. And the attractiveness of including RNAi with, for instance, immunotherapy, is the notion that surface antigen secretion, which we see in excess in chronic infection, may actually contribute to the subversion of those host immune responses. So knocking down surface antigen may have a net effect potentially of liberating some of those immune responses in addition to what immune therapy strategies we're talking about. So it's quite possible that combination approaches then may result in even more impressive responses in terms of recovery of immune responses against hepatitis B. This is a really excellent question, and we certainly have made revolutionary advances with the introduction of curative direct-acting antiviral therapy for hepatitis C. I mean, it's really been an extraordinary marvel to see the cure rates approaching 98 to 100% in our patients with chronic hepatitis C. And yet, in those patients with more established fibrosis, i.e., advanced fibrosis and cirrhosis, who have achieved sustained response, and that's the great majority of those patients who achieve a sustained response, there is a reduction, but not an elimination, of the risk of those patients for progression to hepatocellular carcinoma. So an important practical element of this is that in patients who do have advanced fibrosis, we're not completely done with managing those patients because they still have residual liver disease that puts them at risk for HCC. Now that risk goes down by about 70-75%, but still there is a remnant risk for HCC progression. So those patients need to continue to be surveyed for HCC moving forward. So you get at the mechanisms of that persistent risk. And so when we think about HCV, we have to state that it's different from hepatitis B virus, another well-known virus that causes and contributes to liver cancer. But its mechanisms are going to be different because HBV as a DNA virus integrates into the host genetic material. And so there is the very real possibility of an insertional mutagenesis event occurring in hepatitis B infection. In contrast, in hepatitis C, there is no integration or latency of this virus. So that cure, in fact, is achievable because this virus must continue to replicate for its viability. And that, in fact, is the reason that we can achieve cure in so many instances of chronic hep C infection. So what goes on there in terms of this persistent risk? Well, HCV, it is known, affects multiple signaling pathways, including the epidermal growth factor signaling pathway and other growth-related pathways. The hippo signaling pathway is another example. And the LPA, or lysophosphatidic acid pathway, all are potentially deranged in the context of hepatitis C infection. And those growth pathways may then contribute to the risk of hepatocarcinogenesis. Now, interestingly, one would expect those pathways to calm down after cure of infection, but in reality, studies, transcriptional studies of messenger RNAs in the livers of patients who have been cured for Hep C have shown that these pathways may remain switched on or only partially suppressed despite clearance of the virus. And so this raises questions as to what in the hepatic or liver environment persists now that the virus is gone to explain these persistent alterations. And studies have demonstrated perhaps a number of possible persistent alterations, including the persistence of oxidative stress, which in turn can contribute to hepatic carcinogenesis, as well as so-called epigenetic changes not so much in the DNA sequences themselves, but in the chromatin that surrounds the DNA that lead to its access to transcription of the genetic material. And so these epigenetic alterations may be permissive for more transcription of certain growth-related genes that I described earlier. And so these epigenetic changes may actually be more persistent after chronic Hep C infection and even after clearance of Hep C infection, as early studies have demonstrated. So we think there's probably some other mechanisms at work that differ from those that we historically have attributed to hepatitis B, for instance, and that these may remain persistent. And so I think it's important for us to try to understand which among those patients are going to be at risk for persistent hepatic carcinogenesis risk moving forward. And so these prognostic tools, I think, are going to be very important and interesting to develop based on some of these alterations that appear to persist. Yeah, thank you for the question. So I think for hepatitis B virus, it's really trying to understand how important it is to try to restore those immune responses that have otherwise become exhausted. And this is particularly true for T cells, which are really the main engine of clearance of virally infected hepatocytes. But there are other cell types, both innate and adaptive cells, that have been shown to be involved in both viral control and pathogenesis. And so I think it's really trying to understand what hepatitis B, chronic Hep B infection does to those cell types and their disarming of those functional responses over time, as well as, of course, understanding how those responses and how reversible those responses are with proper and appropriate manipulations. Because I think the answer to that question is really going to go a long way towards describing how reversible chronic infection is in terms of restoring those T cell and other immune responses. So that's, I think, going to be the exciting line of work in hepatitis B. And of course, the studies of hepatic carcinogenesis, as well as those that I've alluded to in my answers to the previous question, are going to be very important. And these can be done using cell-based models, animal models of hepatitis B infection, and even so-called organoid models, which really are more representative examples of multiple cells in conjunction and in three dimensions with one another to more accurately replicate the in vivo situation. I think these models are really going to be, I think, most informative in terms of beginning to tell us not only about mechanisms of hepatic carcinogenesis, but as well about the immune response and the reshaping of that immune response and their contribution to functional cure and even virologic cure. From the vantage point of other research on hepatic carcinogenesis, I think, and fibrogenesis and disease progression in general, we've been very interested in looking at so-called chemo-preventive approaches. You know, it's well known that as I said earlier, that there are still persistent risks for patients who have advanced liver disease, not only for hepatic carcinogenesis, but as well for continued fibrosis and disease progression. And we can't transplant all patients. The transplant is just not as widespread enough a resource. It's also labor and capital intensive. And so for those with advanced liver disease, we need to talk about strategies that would keep them from developing the serious complications of that liver disease, even if we can't cure the underlying driver of that disease. That's particularly true, I think, in hepatitis B, and also true in other causes like non-alcoholic fatty liver disease, as an example. So based on the persistence of these gene signatures that I referred to earlier, and the persistence of risk for disease progression and liver cancer, we're examining the role of possible chemo-preventive compounds that might work to block those pathways that I described earlier that may persist in patients, even those patients who are cured for hep C, as an example. So is there a role for agents such as statins or aspirin or even other more specific pathway inhibitors to help prevent disease progression to, again, the feared clinical complications of cirrhosis and liver cancer? So this is an active area of investigation that we have been pursuing. We've also been very interested in investigating the interaction of hepatitis B, as an example, with other cofactors such as fatty liver disease, as well as HIV co-infection, both of which accelerate the course of HBV-related disease and vice versa. We've investigated and are exploring new pathways that may contribute to disease progression for not just HBV disease, but also HIV and fatty liver disease. And we're quite excited about some of our findings in that regard in terms of the contribution of factors such as hypoxia-inducible factor, just as one example. So we're exploring many of these interactions and are excited about the idea of elucidating new pathways that can be specifically targeted to prevent further progression of these important forms of liver disease.